morning, and thank you very much for the kind invitation, and also special thanks for accommodating the change of the date. I was supposed to be here 2 days ago, but now I had some commitments in Oxford, so I really wanted to be here. We will spend the next 40 minutes talking about what, with my team, we have done over the last 15 years. And it's a great opportunity to come and talk to these audiences around the world, because I know you're mainly clinicians with an interest in research, or clinical researchers, clinical academics. I think it's very important to bridge the gap between research and clinical practice. And I hope this could be a good example of a new approach that can really help improve the outcome of our patients. This is my acknowledgement. I'm mainly funded by the National Institute for Health and Clinical Research, which is the research arm of the NHS in the UK. And now, recently, I got a big grant from Wellcome Trust, which is a charity. But I also I have done some work with a pharmaceutical company, as you will see, mainly to get some data for my projects. So the overarching story, and I really apologize, but we need to do some statistics. I know it's boring, but if I have to tell you one take-home message, is don't trust the evidence, don't trust the literature. Be always very critical about what you see published in the journals. So I hope I will give you some very basic tools to understand what is the rationale behind the research I do. And later on, we have the expert session, so I'll be very happy to answer any question about it. Sorry. The example of the antidepressants is an example, but could be anything in terms of evaluation of any treatment, pharmacological and non-pharmacological, for any mental health disorders, and possibly also beyond. And then the story about the precision approach, tailoring treatment to the individual, and I will finish with the Petrushka trial, which is what we are currently doing internationally. Okay, so let's start with some background. This is a paper published 10 years ago in JAMA Internal Medicine, and this is a systematic review of existing studies. And the studies ask patients, what is the most important thing? What do you want as the top priority when you see a clinician across whole medicine? And the answer is, I want to know what is the drug of choice for this condition. Drug is because medicine is mainly about drugs, but this applies also to psychological treatments. So the patients really want to know what is the best treatment for them. And this is the answer. Psychiatry is lagging behind other fields of medicine. If we look at hematology for melanoma, oncology, if we look at vaccines as well, we now have the vaccine against my own melanoma. So medicine is going at a different speed as opposed to psychiatry. And when we talk about precision mental health, even though we have these great examples of fantastic papers published in the literature in very good journals, my point is, it's very small, because we are talking here about a secondary analysis of one randomized trial. And we know we have a huge amount of evidence out there. The other important thing that I want to share as a sort of background knowledge is what Ron Kessler, who is a friend and collaborator, wrote a few years ago in JAMA Psychiatry. When we talk about precision psychiatry, it's important to have a pragmatic approach. And pragmatic means not only looking at the randomized evidence, which is very good if you want to compare treatment, but if you want to know what is the real effect of an intervention in clinical practice, in routine clinical care, you need to use also observational data. And this is the paradigm he is suggesting about this pragmatic approach around psychiatry. A very recent example, just to show that nowadays we have an additional tool, which is digital. We are very, I mean, I'm a clinical academic. I see patients every week in my clinic, mainly with mood disorders. And we have not a lot of time to see the patients. Everything is running at huge speed. You need to look at a lot of records. You need to do the blood test. You need to have a lot of information. So now researchers are trying to test innovative ways to help clinicians in the shared decision-making process. And this is an example from the top journal we have in medicine, which is The Lancet, about computerized decision support alerts. It's basically a pop-up coming when the doctor is seeing a patient just to help the management of the patient. And the paper is a lot about the sort of alert fatigue. If you are bombarded by alerts, it's like having nothing. It's the problem also with emails. But this is interesting. The accompanying comment, the editorial, said something that I'm using now to support my work. So it's very selfish, but I think it's great. So although these results are exciting because they were shown on a large scale across several centers, they merely confirm what the literature had already identified. Yes, alerts work, but in the current era of increasing computing power and artificial intelligence, the challenge is not to show that simplistic clinical decision support systems work, but to create systems that are smarter, more user-friendly, more interactive, and have a higher positive predictive value. And I, as a psychiatrist, I want to add another big pillar to this picture, which is patients. So we need to incorporate their views into the shared decision-making process, because each one is different in terms of preferences, in terms of biology, and all these variables. Okay, so having said this, now the problems. This is a paper published many, many years ago by Stefan Leucht, who is a friend and colleague. And I like the title because that's exactly the point. Okay, so we need to start from the evidence. But the evidence is conflicting. So if you look at, this is an example about antipsychotics for schizophrenia. So why olanzapine in a paper beats risperidone, in another paper risperidone beats quetiapine, and in the third paper quetiapine beats olanzapine? It doesn't make any sense. This loop is inconsistent. So the answer is the standard methodology of evidence synthesis, what we call pairwise meta-analysis, comparing two pairs of treatments, doesn't work. Or it doesn't answer the clinical question we have as clinicians, which is how the different treatments compare against each other and how big are the differences between treatments. So we and other researchers, of course, over the last 15, 20 years, we have developed this new approach called network meta-analysis. Okay? Again, don't trust me. I want to show you the value of this approach. So this is the standard pairwise meta-analysis. I want to know what is the effect of treatment A versus placebo. I collect all the randomized controlled trials about A versus placebo, 3 studies. I lump them together. I merge the study. I have a pooled weighted estimate telling me in one number the summary of 3 different studies. So it's a great achievement. I summarize the effect into one figure. And I do the same for B versus placebo. Out of 4 different studies, a different pooled estimate. So I have 2 sets of data, but that's the problem. If, as a clinician, and if you allow me as a patient, I want to know what is the difference between A and B, and assuming this is the entire amount of evidence, because we know that pharmacological treatments are heavily biased by industry interests. So we need to help industry and regulators design the best studies. We don't have data comparing A versus B. So what do? There's a gap. Shall we leave it as it is? Or can we have a robust methodology to answer this question? And the answer is network meta-analysis. Because if you see here, in this set of studies and in this set of studies, there's something in common, which is placebo. So if I can combine placebo from group 1 and group 2 into one big sample of patients, then I can compare indirectly A versus B via placebo. Okay? So this is in a nutshell what network meta-analysis is. It's a way to have direct and indirect evidence combined together, not only to fill the gaps in the knowledge, but also to have better precision, because combining direct and indirect evidence, I can increase the statistical power, because the more the patients, the more precise is the estimate, the smaller is the uncertainty around the effect. And if you want to learn more, this is a paper we published 10 years ago in evidence-based mental health. It's free, it's online, but if you have difficulties in finding it, drop me an email and I'll send you the PDF. This is a tutorial, if you want, a primer about the methodology of natural meta-analysis and all the issues around the visualization of the results. Okay, so this is the methodological part. In terms of the overarching story, this started about 20 years ago when I was doing my residency in psychiatry in Italy. And in the Italian system, we used to see patients from any disorder, including depression. And I was struck by depression because when we were discussing about antidepressant treatment with my supervisors and teachers and colleagues, we have 30, 40-ish drugs on the market that we can use. And on one hand, I noticed that my colleagues then usually use 2, 3, 4 options, no more. The second point, I asked, what is the rationale to choose one or the other? And the answer was, don't worry, they're all identical, just prescribe the last one on the market because they have fewer side effects, and we have the rep from a pharmaceutical company to allow us to go to congresses around the world. So it's very, from an ethical point of view, it's quite difficult to justify this answer, I think. So we started about, yes, the first big paper was in 2009, so 15 years ago, but the work was much longer in preparation of this paper in the Lancet in 2009. So we started summarizing the evidence and using the natural meta-analysis approach. And after many years, however, we published this paper in 2018, which is, just to cut a long story short, probably the most important publication of the story around antidepressants, because it is aimed at answering a clinical question, a research question, but also it is an example of an approach that can be used for any disorder and any treatment. Okay, so what we did was to start with the rationale. We know the antidepressants are first-line treatment for depression across the world, but at that time, and still now, especially in some countries, there's a long debate about whether they really work. And the second point is, if they work, are they identical or are there differences between drugs? So from a clinical point of view, we start with the acute presentation of the symptoms, because you see the patient when they are depressed. And doing a systematic review and natural meta-analysis implies to be focused about the clinical question. We can't cover everything. So this is just the first step for the treatment of patients with depression, because it's the acute presentation. The maintenance is a different thing, it's a separate piece of work, and so on, okay? And also we focus on adults. I'm an adult psychiatrist, also because the effects of antidepressants in kids are different. So we wanted to be homogeneous in the patient population. And we focus on unipolar major depression, because bipolar is a different story. So the aim was to compare all the licensed second-generation antidepressants. Why? Because guidelines now say start with a SSRI onwards. Okay, that's true for NICE, for Australia, for US, Japan, everywhere in the world. But we also wanted to have a reference with the first-generation antidepressant, the old drugs. And we used the WHO list of essential medicine because we wanted to have a global impact. And in order to answer the first question about whether antidepressants are efficacious, of course, we wanted to have a placebo control. This is the long list of 21 drugs, from 1 to 17, the second generation, the newer or newest antidepressants. The last 4 are the 2 drugs, antidepressant drugs, in the WHO list of essential medicine, trazodone and nefazodone, because especially in the US and in Europe, are used because of specific side effect profile, and they are quite common in clinical practice. As I said, we excluded bipolar, psychotic, treatment-resistant depression, and also people with concomitant medical illness, because they have additional treatment that, like steroids or whatever, that can affect the effect of antidepressants. Outcomes, we focus on pragmatic outcomes, and this was done with patients. So they said, I want to know after 8 weeks if I responded to treatment and if I am still taking the medication. So the 2 primary outcomes were response rate, 50% reduction on a rating scale. This is a pretty standardized measure across RCTs, and all-cause dropout, which means discontinuation rate. But we also look at change in symptoms, remission, which is below a certain threshold of score, and discontinuations due to adverse events. Because this is a clinical study, we used data from drugs only within the therapeutic range. And when I say all licensed drug, is all licensed drugs across the world. So some drugs are not licensed in Europe, but they are licensed in the US. Okay, so this is the network. Now you see why this is called network meta-analysis. On the left-hand side, we have the network for response. On the right-hand side, orange, the network for all-cause dropout. So these are the 2 primary outcomes. I'll explain how to read the network. The lines represent the trials comparing one versus the other. And the width of the line is proportional to the number of trials. So we have trials comparing desvenlafaxine and placebo, but we have more trials comparing fluoxetine and placebo. We have fewer studies comparing fluoxetine with mirtazapine. We don't have studies comparing mirtazapine with nefazodone. So it's synoptic. You can summarize all available data. And the size of the node is proportional to the number of patients randomized to this drug. So we can see that a large sample is randomized to placebo, as expected, also to fluoxetine because it's an old drug, a lot about paroxetine, very few about milnacipran or levomilnacipran because these are a recent drug or less studied drug. Okay? So going back quickly to the question about methodology. I told you about direct and indirect, so it's crucial that we look at the shape of the network, what we call geometry. Because if we have many lines in the network, it means we can check the indirect evidence, which is called inconsistency. And this network is very well connected. There's a lot of lines here. The second point is, in terms of the shape, this network, shape-wise, is very similar to this network, which means that the patients that were assessed for response rate are exactly the same patients assessed for all-cause discontinuation. So our hypothesis of the 2 primary outcomes, patient who responded is still taking the medication, holds because the same study, the same patients are contributing to both outcomes. These are the results. So this is efficacy, and on the right-hand side favors the drug, on the left-hand side favors the placebo. All drugs are better than placebo. This is a forest plot, but we are summarizing all network meta-analysis data. The most important thing is, everything is on the right, so antidepressants on average are better than placebo. Second, if you look at the top one and the bottom one, the confidence intervals do not overlap. So it means that top to bottom, there are material differences between the drug. In terms of efficacy, because if you look at dropouts, you see that the great majority are with the confidence interval crossing the line of no difference, so no difference at all. The first top two are better than placebo, and clomipramine is worse than placebo. but you see the confidence interval, which is the precision of the estimate, is almost kissing the line of no difference. So clinically, I would say, well, there are not big differences, because you can't be certain about whether what is better or not. So no differences in terms of acceptability. And this is what we do if we plot on the x-axis efficacy, on the y-axis acceptability. This is exactly these two forest plots in a bi-dimensional graph. Okay? Look at me. 16 is reboxetine, the least effective. 22 is placebo. Everything else is with different numbers. So in terms of efficacy, all antidepressants are better than placebo. In terms of acceptability, they are all the same. Okay? I'm repeating what I just said. But look here. This is all studies. What happens if we remove completely the studies with placebo? So we basically delete 22 and repeat the analysis only active versus active. The result is this. 16 is in the same place, but the differences between antidepressants are much bigger if you exclude placebo-controlled trials. And that's a problem, because we made an assumption at the beginning. So this is the figure in the Lancet. I added the question mark for the purpose of the meeting, but that we wanted to show the inconsistency between the two sources of evidence. And we did a specific study before publishing the paper in the Lancet to understand what the problem was. And the problem is this. If you take the same molecule, so the same active ingredient, and you test the drug in a placebo-controlled trial or in a head-to-head trial, so without placebo, you see this. Black dots without placebo, the same drug has higher response rate and lower dropout rate, as opposed to the same drug, blue dots, in a placebo-controlled trial. So if you test the same molecule with placebo, and there's a placebo in the trial, you see that it's less effective and less tolerated than the same molecule in a head-to-head trial. Many, many explanations, many question marks. I'm happy to go back to this during the Meet the Expert session, but the bottom line is adding placebo is a confounder. For this reason, we use this plot to build the 2x2 league table where we have all the data together in one page. So these are the drugs in alphabetical order. There's no placebo here, from agomelatine to vortioxetine. Left bottom triangle is efficacy, response, and top right is discontinuation rate. And you go down the column defining drug and the row defining drug, you see that agomelatine versus reboxetine, highlighted and bold, are statistically significant results. So if you look at the efficacy, there are many cells highlighted and bold. If you look also at tolerability, dropout rate, they are also highlighted and bold, which means all antidepressants are not created equal. Limitation of the study, many. We may have missing studies. Of course, the certainty of evidence was low to medium or sometimes very low, but that's the evidence we have. We didn't do any cost-effectiveness analysis, so it's difficult to translate this into practice. We may have missed some effect modifiers that may have an impact on the estimates, and of course, we look at very pragmatic outcomes. For instance, we didn't look at specific side effects, which is what we're trying to do now, or global functioning. So all these are generic limitations, but for the purpose of this presentation, this is the most important limitation. If I want to use this evidence, top journal in the world, largest network meta-analysis ever done in medicine, okay? So that's the best we can do. We still have average effect. How can I use an average effect to treat my mom? So can we use available evidence to personalize treatment in real world? Because that's the other challenge, hence my hint about the digital, because we have a very small amount of time, and we need to do this in the clinic. So there's another small step. When I presented the data about the natural meta-analysis, what we did was to have an average effect from each trial. In this paper that we published more or less at the same time, we did something different. We used individual data from each study. It's a very simple individual patient data natural meta-analysis, but it's very good to show what I want to show you, which is Helen and Steve are in the same study. So if I take the average effect from this study, it's the same. However, Helen is a female. She has a long history, severity of depression. She's quite depressed, very anxious, very young, no family history of depression, and short duration of symptoms. These are the so-called effect modifiers. And you can see that over 12 weeks of treatment, this is the change in depressive symptoms if she takes A, B, or C. So it's clear that for Helen, C is the best option. And I can also tell Helen the first 3-4 weeks, there's no real material improvement, but then it will be steady and progressive. So you can also predict what is the trajectory of the symptoms. For Steve, man, less depressed, same level of anxiety, older, with family history of depression, and longer duration of symptoms, B is the best. So if we use clinical and demographic characteristics as predictors of response, in this case is response, we can go a level deeper. From the average, we can actually stratify treatment. Because if you are a man with this severity, with this age, and this past history, probably it's more sensible to give you B rather than C. So we manage using the data, so this is evidence-based medicine, okay? Using the data, we can stratify the treatment, but can we personalize? I thought a lot about this, and to be honest, the best answer we have at the moment is this. Asking patients about their preferences of side effects. Because if Steve, 58, blah, 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 if you ask Steve to say how important are these side effects, he says insomnia, not really, no nausea, very important sedation and weight gain. He doesn't want these two. Tremor is a bit in the middle. And as a doctor, I can do an ECG, I can find the QTC is not prolonged, so I can say no hypertension, so no cardiac risk. So I can use also the medic as an input. This is the ranking of the treatments recommended using the natural meta-analysis of individual patient data. So A is the best choice, and E is the least, the fifth, sorry. But if you have Nick with the same baseline and demographic clinical characteristics, but with different preferences, he doesn't want nausea and tremor, and he has hypertension and QTC prolongation, you can see that what was the fourth-line treatment becomes the first, and new interventions are recommended. So this is the paradigm that we use to develop Petrushka. This is the protocol of the trial. Petrushka is not only because I love Stravinsky, it's an acronym for personalized antidepressant treatment for unipolar depression, combining individual choices, that's the S, risks, the K, and big data, the A. So forgive me. And that's the protocol. So again, it's open access. And this is what we do. We have a website, and we are doing the trial. So the idea is to use the randomized data from the Lancet 2018. We contacted the companies. We got about 100 out of 522 trials, including the review. We got individual patient data from 130 RCTs, still the largest comparative data set of individual patient data in mental health, 40,000 patients, about 16 antidepressants and placebo. So these data are used to assess the relative effects between treatments. We use real-world data, observational data from Q Research, which is a UK large data set with 35 million people. Out of them, we identify 700,000 people with depression taking the antidepressants, for whom we have all the characteristics in terms of the predictors, but also the effects in terms of changing symptoms and so on. And we use the real-world data to predict the absolute probability of having an effect, response, or dropout. And the third pillar is preferences of patients and clinicians about side effects and also the risk in terms of other comorbidities. So combining these three pillars, we developed a web-based clinical decision support system called Petrushka tool, and we're now about to complete the trial. So I can't show you the results because I don't know the results yet. We're still recruiting until the end of June, but I can tell you a lot about the preparation. And if you invite me again in a couple of years' time, I'll be able to show you. So that's the lesson from COVID. We want to do hybrid trials. We don't want necessarily to have people coming in person. So we have everything online. Everything can be done remotely or in person. Teleconsent. It's an adaptable tool. I'll show you why. Because some people, if they have tried some antidepressants in the past, there's no point in having the antidepressants in the pool of potential options. When I present this to lay audiences, in my mind, the Petrushka tool, the back end of the system that we analyze both with machine learning approaches and statistical approaches, is like Google, like a search engine. So you enter the characteristic of the patients. We have this back end, which is producing an output, which is the answer to your question, what is the best treatment for this individual? Of course, if the patient has tried citalopram, there's no point in having citalopram in Google. So we need to adapt the tool to the requirements of the individual patient, but also of the the healthcare system, because this is an international trial, so we have UK, Canada, and Brazil, as you will see. In the UK, bupropion is not licensed as an antidepressant. In Brazil and Canada, it is. So we have some drugs that are in one country and not in another. Because the overarching idea is I target the treatment as best as I can. And also the follow-up visits are hybrid, and we ask patients to complete self-rated questionnaire, and we ask clinicians to do the observer-rated questionnaires. So it's a single-blind trial because patients and clinicians know what they are doing, because if you do the Petrushka tool, it's clear you're doing the Petrushka tool. The blind person is the assessor, because they do telephone assessment, train people, psychologists, and research assistants, and they don't know if the patient they are assessing is Petrushka or usual care. These are the two arms, usual care versus Petrushka tool. The primary outcome is all-cause discontinuation, also to match the fact that it's an open trial, but we have also symptoms of depression, anxiety, quality of life, and cost effectiveness. The primary outcome is after 8 weeks, in line with all the other studies, and it is a 6-month follow-up. We couldn't do the 12 months as we originally planned because of COVID, which was a big disruption, so we had to reduce the time, but it's better than nothing. 504 patients in total, 252 per arm. It's a 1:1 randomization ratio, and we target patients with moderate to severe depressive symptoms who want to start an antidepressant and for whom an antidepressant is indicated. These are the same patients in UK, Brazil, and Canada. The difference is in UK, these patients are primary care patients. In Brazil and in Canada as well, they are all secondary care. And that's a variable that may affect the outcome. But that's the beauty of the study, which is international, and hopefully will have more generalizability. Briefly to show you the tool, I'm very proud. That's my third kid. I spent a lot of time developing it. And the idea, because it's remotely, is you have the medic and the patient, two different screens, but the clinician, because we also have nurse prescribing, the clinician can see what happens in the patient screen. So Oxford Blue is the clinician we reverse the color. The gold is the patient. When Petrushka is gold, is the patient. You will see in a second. So this is, again, the clinician, and this is password protected, of course, with username and password. And what we do is to have all the available patients in the GP practice, because in the UK, GP cross-cover each other. So this is your own patient in blue. These are the other patients in your clinic, if you want, and they can help each other. Of course, everything is anonymized, but we need to be able to identify the patient we have in front of us or on Teams. So, as I said, first step before we invite the patient to join is to exclude drugs that were tried, and, for instance, citalopram here, we have to select the reason why we excluded, and it was previously tried, not tolerated. So citalopram for this patient will never be recommended. Then we start the session, and this is what the patient sees, okay, the gold frame. This is the username of the patient. So the first step is for the patient, so only the patient can click on the tab, is to choose 5 out of 10 adverse events that they don't want, okay? So they choose the 5 here in alphabetical order. The next screen is to rank the 5 from number 1, the adverse event they most want to avoid, to number 5, the least they are bothered about. And then the third screen is, if the first one, headache, is the top one, so 100 point, how big are the differences between side effects? They can have all 100, they can have 100, 0, they can do whatever they want. They move the sliding bars to show how big are the differences, and they are helped with numbers, okay? After this, there's no way back. They press the button, and now the button goes back to the clinician, because this is the TripAdvisor-like presentation that patients wanted, because initially we developed a sort of demo with numbers to show in percentage what is how strong we recommend this drug, and they said, no, too many numbers. So it's just visual, the overall score, but it's quite intuitive that the difference between number 1 and 2 is relatively small, but number 3 is probably not worth considering. But then that's the most interesting part of the algorithm, if you want, which is I can tell you exactly what is the probability for you to have each of the 5 adverse events you've chosen, comparing 1, 2, and 3. So headache, 20%, sleepiness, 6%, and so on. Here, there's an information also for the medic, because these percentages are quite similar, except sleepiness. So it is true that there's a small difference in terms of sleepiness, but probably the big difference here is driven by the efficacy, because this number is a combination of efficacy and acceptability, so the likelihood of stopping the treatment. So probably number 1 is more efficacious, but in terms of side effects is also slightly better, okay? And the clinician, on their own screen, they also have a long list of 30 adverse events, and we use it to discuss with the patient, because they didn't choose weight gain, but I can tell you, if you take number 2, the weight gain is 2%, if you take number 1, is 15%, and this may be something that they want to consider. So it's a real shared decision-making shared decision-making process with evidence-based. Petrushka trial, as I said, UK, Canada, actually it's Toronto. I pretend it's the whole country, but it's Toronto and Brazil. We won the prize, and you know, in the UK, everything is competitive, especially the academic world, but I'm very proud that the NIHR gave Petrushka the prize last year of the best study across not just only mental health, of course. So Petrushka is part 1. Let me show you what I have been working on in the last couple of years, and we are almost reaching the finish line for another big funding for Petrushka tool Petrushka 2, which I called PRADA, prescribing the right agent for depression in adults. Because we want to go a little bit higher in terms of sophistication, and in PRADA, if we get the funding, we will use another important predictor in mental health, especially depression, but also psychosis and other disorders, which is genetics. So the idea is to include pharmacogenomics and polygenic risk scores in this study. The second thing is to go real global south, so we have Nigeria and Pakistan. And the study is, as you can see, more complicated from a methodological point of view because it's a smart design, so a sequential and adaptive trial, and comparing all the current Petrushka tool with the enhanced tool, which incorporates genetic. We have a first randomization, then a second randomization only after 4 weeks, hence the early intervention, a third randomization at 8 weeks for the long term until 1 year. I'm happy to answer any question when we discuss later today. As I said, it's a group effort. This is part of the team. Many people now have added. I didn't have the latest figure, but these are the people who mainly contributed to Petrushka. And of course, this is my email if you want to reach me offline. Thank you very much.